Well, thank you for that very kind introduction. And it's lovely to join the Korean Psychological Association on your conference, and I'm very grateful to Dr. Choi for the invitation. I know that as an association, you have been working very hard to improve the mental health services here in Korea, and I'm here to just share with you some of our experience on a similar journey in England, and to hopefully give you a little bit of extra ammunition for persuading your government to further develop psychological therapies for your people. Oh, I've gone one too far. Can I go back?
So you can just click for this side.
And that will go. I want to go back to the previous one. Ah.
Let me give you another.
This is the disadvantage of not reading Korean, so I can't see what my mouse should be doing. Great, thank you. Oh. Yeah. So back in 2012, you'll be aware that the OECD issued a report on mental health in Korea, and at the time argued that provision was too much focused on inpatient care with very long stays for patients, and commented on a very marked discrepancy between how common particular mental health problems were, particularly anxiety and depression, and the proportion of people who were getting treatment for them, which was very small. And one of the recommendations was to change the model of care from inpatient institutions to community care. And rather surprisingly, it also said, consider a large-scale program to improve access to psychological therapies based on the English experience, which was considered to be likely to be cost-effective and would also begin to tackle levels of stigma. As I was the architect of the English experience, I'm going to tell you a bit more about that now. But before that, I should congratulate you all on recent developments, and particularly the National Mind Investment Support Project, which I understand is providing vouchers for up to 8 sessions of psychological counseling for people with common mental health problems, which is a very important advance. But you will see in my talk that some of the key features of the system that we have found very successful in England are not quite in the voucher system yet. So the program that was mentioned in the OECD report was known as Improving Access to Psychological Therapies, or IAPT. Our politicians have now changed its name to NHS Talking Therapies, but it's the same service. And it was created in order to deal with an injustice. There really were new prospects for the treatment of mental health problems. Over several decades, psychological researchers had developed effective psychological treatments that could be used in most of the common mental health problems, particularly depression and all the anxiety disorders. And they're quite short-term, 14 to 20 sessions. And our government body recommended them for routine use. Surveys also showed that this would be popular with the public. So when people were asked, if you had a choice between drugs, which can be effective, or psychological therapy, which would you prefer? And some people said, give me the drugs. But in a ratio of 3 to 1, people said, I would prefer psychological therapy. But in no country in the world was the public getting what it wanted. There was no country where psychological therapies were more commonly available than drugs for mental health problems. And in the UK, the situation was bad. Only 5% of the people with common mental health problems were getting an evidence-based psychological therapy. Somewhat more were getting some psychological input, but it wasn't necessarily an evidence-based treatment. And people often had to wait over a year to start treatment. So that was the problem that we were trying to solve. And the IAP program is essentially a promise to the public. It said, we will create new psychological therapy services, and if you're treated in that service, you will always get the, what we call NICE recommended or clinical guideline recommended psychological treatment for your particular problem. It will always be delivered by therapists who've been fully trained in that therapy and have been accredited for delivering that therapy. And we will monitor the outcomes of every single patient who is treated in the program, and we will publish those outcomes, not for each patient, but for each service. So this was an exercise in public transparency about our mental health services. And the idea was we'd learn from that data in how to improve things further. The arguments for this program were put forward in a book called Thrive, The Power of Psychological Therapies, the Korean translation of which will be available in a few days, I think. But essentially, it was saying that there is quite a lot of evidence that you can train people in routine services to deliver therapies at scale and effectively, and that as long as they're well trained, this initiative will not cost the government any money at all. And the reason is because if people recover, then the government saves a lot of money. People with anxiety and depression have a lot of extra investigations for physical health problems, and so they would save in their physical health budget. But also, they're less likely to be in work, and if they are in work, their mind is often somewhere else on their worries and their depression, and so they're less productive. So if you can help people recover from their mental health problem, it improves the economy by getting people into work and making them more productive. And we argued that if people had an average of 10 sessions of therapy, then the savings would be greater than the cost of the program. The first Prime Minister to accept that argument was Gordon Brown, and he provided initial funding for the program. You will notice, I don't know if you know about this in the Korean media, but we change our Prime Ministers quite often at the moment. Our shortest lived one was just 42 days. She's not on this slide because she didn't have a chance to talk about the IAP program in 42 days. But all the other Prime Ministers have expanded the program. So it's had consistent political support. It started small in 2008, just saw 93,000 people, and it cost £33 million. But now we are at a point where we see and treat 670,000 patients every year. We give them a simple measure of anxiety and depression each time they're seen. So even if they drop out of therapy, we know how well they've done up to that point. And we managed to get outcome data on 98% of that 670,000 people. When we started the program, I promised the minister that if we train people well, we should be able to get about 50% of people to fully recover from their anxiety and depression, and that's this red line here. And about 2/3 to show marked improvement. And when he announced the program on national television, said 50% of people will recover. And I nearly had a heart attack because I realized that we had to deliver on the promise. And you see, this is the data, the national data, and you can see at the beginning of the program, we actually weren't at that 50% rate. We were somewhat below. But over the years, we've got better and better, and since 2016, we've been at least at 50% recovery, and about 2/3 of people showing really worthwhile improvement. And the service is now sort of being copied in a number of other countries: Norway, Ontario, Australia, Finland, and Italy. So if, however, we weren't collecting the outcome data, we would have continued at this sort of lower level of about 35–40% of patients recovering. And as clinicians, we would be blissfully ignorant of that point. But around about 100,000 patients every year that we could have got to fully recover would not be recovering. But because we collected the data, we could see we weren't doing so well, but we also could learn what were the ingredients needed to do a lot better. So what have been the keys to the success of the program? Well, the first one is to have national training curricula for our courses, where we make sure we train people to be fully competent in delivering the different therapies. And we only pass people out at the end of a course by watching videotapes of their sessions with patients and checking that they have all the relevant skills to deliver the treatment properly. And we have professional organizations like the KPA to accredit therapists. We also ensure that all the therapists get regular, and that means every week, clinical supervision to maintain their clinical skills. And then we use this simple measure each time someone's seen to monitor patients' outcomes. And I think the monitoring of the outcomes has been the most important magic ingredient. You saw that initially we weren't doing as well as we hoped, but that by collecting the data, we were able to do much better. And we've learned many lessons from looking at the data, and I'm going to mention some of them to you. So the first one is, it's very important to follow the clinical guidelines about which treatments are most effective in research studies for which clinical condition. In England, we have a lot of very experienced clinicians, and when they're on holiday, they sometimes ski off-piste. And when they come back to work, they sometimes think, oh, I'm not going to bother with the clinical guidelines. I know what I'm going to do with this patient, and they do something different from what's recommended. This was a huge natural experiment. So we could look at, do patients benefit when the clinicians decide to do something other than the clinical guidelines? And the answer always has been, patients suffer when we do that. So, for example, the clinical guidelines recommend both cognitive behavior therapy and counseling, non-CBT counseling for depression. And we find that you get equally good outcomes with those two approaches. But for generalized anxiety, the clinical guidelines say only use cognitive behavior therapy. But many of my counseling friends say, but we know we do very well with people with generalized anxiety. And when we looked at the data, they were right. 48% of patients with generalized anxiety fully recovered. But what they didn't know is that the people who got cognitive behavior therapy, 58% fully recovered. So it makes a difference. And we found whenever we look at people deviating from the clinical guidelines, our patients do less well. So the first thing to say is it's very important to ensure people get the right treatment delivered by someone who's properly trained to deliver it. But it turns out that is not enough. It also depends on how you organize your services. And this slide illustrates this point. So we have about 200 of these services, and although on average they get a recovery rate of 50%, some do quite a bit better than that, and some do less good. So we could analyze what are the characteristics of the services that do really well, and we found several key features. The first is the quality of the assessment. If the services are very good at identifying the particular problem to focus on in treatment right at the start, is it post-traumatic stress disorder, is it depression, is it social anxiety, then they get better outcomes, presumably because they give the right treatment. Also, how long you wait before you start treatment seems to be important. Many of the patients we see have had their problems for many years, but when they've decided to come for treatment, it is important that you start quickly. And this is shown on this slide here. What I've plotted here is the average number of days you have to wait before starting treatment in your service, and then we have the probability of improving at the end of treatment. And each blue dot is about 5,000 patients. It's all the patients treated in a particular service in a year. And you can see it doesn't matter how long you wait to start treatment. For the first 6 weeks or so, you still get very good outcomes. But once you're in a service that on average waits longer than 6 weeks, although the treatments are the same, the outcomes are not so good. So this led our government to say everyone should start treatment within 6 weeks. It also turns out that a bit like with drugs, there's a dose-response effect. Those services who give a higher average number of sessions get better outcomes. At the moment, the average number of sessions is 8, but in my original calculation, I thought it would be 10. And it turns out the analysis shows that the optimal results are with 10 sessions on average. But of course, that means some patients will have 20 or 30, and some will have less. The other thing we discovered is that if your service is in a very deprived area of the country, then on average, patients get less good outcomes. Why is that? You might say, oh, well, if you have very difficult social circumstances and low income, then psychology can't help you. The alternative, though, is that when you live in one of those deprived areas of the country, you may also be deprived of a good quality psychological service. So you can test this out by essentially saying, does social deprivation still predict outcomes if we statistically control for these sort of quality features of a service? And we did that in our Lancet paper. And it turns out that if you get the quality of the service good, you get just as good outcomes in a deprived area as in an affluent area. And you can see this on this slide. So I've chosen 2 areas of the country which are next to each other. One is Windsor. This is where our new king, King Charles, has his weekend castle. And this is a very rich area of the country. It is not at all socially deprived. It's at the 4th percentile of social deprivation. But right next to Windsor is an area called Slough, which is one of the most socially deprived areas in the country. Both areas are served by a single, very high-quality IAP service. And you can see that both areas get recovery rates above the national target. And in fact, if anything, Slough does slightly better. So if King Charles, under all the stress of being a new king, felt that he could have some psychological therapy, we might suggest he asks his chauffeur to drive him a bit further down the road to Slough. So this takes us to another point, which is inequalities in healthcare. If you collect data on everyone, you spot lots of variation. But that's great, because once you know about it, you can solve it. And this slide here shows that in the early days of the program, in 2015, we had a big difference in recovery rates between people from the white population and then people from two minority ethnic groups, the black population and the Asian population. That is not okay. You clearly need to design your systems to be effective for everyone. But although this was true in general, when you looked at individual services, there were some services that were doing very well for these different ethnic groups. So we visited them and found out what they were doing and wrote all that up in a positive practice guide, which was then distributed to all the services. And you can see that since we did that, the recovery rates for all groups have improved, but we now have no difference in outcome at all between the white and black populations. And the difference to the Asian population is now very small and is restricted to one particular group, actually, the group from Bangladesh and Pakistan originally. And we will abolish that difference as well. So you can do wonderful things as long as you get the data. One of the big developments in psychological therapies in general around the world is what we call internet therapies. In a psychological treatment, you're learning new skills to deal with emotional problems. One way of doing that is to sit in a room with a psychotherapist and have a conversation. But you can also learn a lot from the internet. And so we put a lot of the key ideas in the psychological therapies into online internet programs. You still have a psychological therapist, and they support you through the program, but the time they spend with you is much less because a lot of your learning is done on the internet program. And we're finding that for patients who would like to be treated that way, and it needs to be a patient choice, we find that that has some advantages. It means they don't have to travel to a clinic. They may feel less stigmatized because of that. They can study at a time that they find convenient. And we are finding that we're getting as good results with the internet treatments as with the standard face-to-face therapy. And on this slide here, you see one of the internet treatments developed by my group in Oxford. It's for treating social anxiety disorder. We developed the leading cognitive behavior therapy program for social anxiety. And in a recently published randomized controlled trial, we either gave patients the normal once a week for 90 minutes psychotherapy sessions. And you can see in the blue line here, this is the average social anxiety. And for each extra hour of therapy, because we're plotting increasing hours of therapy here, you see there's benefit. So right up to 20 hours of therapy, on average, people are finding each therapy hour helpful. But if instead of having the standard face-to-face therapy, you had access to the internet program and much shorter remote support from the same therapist, you can see you get to exactly the same outcome, but in only a third of the therapist's time. So we can treat 3 times more people with the internet therapies than without them. And these are giving very good recovery rates. Of course, it's not just being alleviated from your symptoms that psychotherapy aims for. You really want people to be able to be freed to live the life that they would like to live. And so in this trial, we also, at the end of treatment, ask people, do you feel you're more or less able to live the life that you would like to live? And with the internet program, we found 91% of patients said, I am more able to live the life that I would like to live. So these are powerful therapies that transform people's lives. In a short talk like this, of course, I can't take you through the details of the therapies, but if any of you are clinicians and are interested in what happens in the therapies, we have a free therapist resources website, www.oxcadatresources.com. And if you'd like to use that website, you're very welcome. You can register and then have free access to it. You'll see full-day workshops, free, on treatment of PTSD, traumatic bereavement, panic disorder, social anxiety disorder, lots of questionnaires and therapist manuals. And it is currently being used by therapists in 176 countries. Round about 40,000 therapists every day use it. So you will be joining a big international community. And we update it every week with new resources. So it's yours if you would like to look at it. But I'd like to end up by coming back to the argument that was used for creating the IAPT program, which was to say it transforms people's lives, it allows them to do what they want to do in life, but it also helps your economy because it doesn't cost you anything and you get people back into work. That was the argument. That was based on research studies at the time. But now we're nearly 20 years into the program. What does the evidence say? Was that argument right or not? There's now quite a lot of evidence which shows that we were correct. And this uses often data linkage, where we link the talking therapies data set to other data sets. First, within physical healthcare, and we have studies that show that treatment in the NHS talking therapies services reduces your subsequent risk of being admitted to hospital for outpatient or inpatient care for physical health problems. And that alone largely covers the cost of the program. We've shown, for example, that if you follow people up for 3 years after the end of the psychological treatment, those who recovered from their depression have a significantly lower rate of adverse cardiovascular events, including stroke and heart attacks. We've also shown that if you follow people up for 8 years after successful treatment for either depression or anxiety in the talking therapy services, people have a lower rate of a new diagnosis of dementia. So there really is a strong body-mind connection here. What about the argument about employment? Well, on the right-hand side of the slide, you can see what happened when, in some areas, we introduced a new service that focused on anxiety and depression, particularly for people who also had a long-term physical health problem, like a cardiovascular problem or diabetes. And we introduced those services earlier in some areas than others. And the areas where the introduction was delayed became the control group. And you can see this is the proportion of people who are in work, that if you go into the new service, then you're more likely to be in work at the end of your treatment than at the start. But if you're in an area that doesn't have that service yet, then actually, during the same period of time, you're likely to lose your job. So there's a big difference in employment. I said that some other countries have been following this program, and this is really wonderful because it means that they also contribute data that look at the importance of making effective psychological therapies available to our public. One of the nicest research studies comes from Norway, where they adopted essentially a copy of the IAP program, and it now covers almost all of the country, but they gradually rolled it out in different areas. And after a few years, when they got to a new area, they decided to do the rollout as a randomized controlled trial. So patients were either randomized to the new IAPT-like service, it was called prompt mental health care, or to treatment as usual in primary care with their family doctors. And they found that treatment in the IAPT service doubled the recovery rate from your anxiety and depression, but they also followed everyone up in the trial for the next 3 years and looked at whether they were employed, whether they were receiving state unemployment benefits, and also what their income was. And what they found is that those people who were treated in the IAPT service were more likely to be employed and were less likely to be receiving state benefits. They also had a higher average income. Now, that is a really important statistic because you can work out the extent to which the treatments are growing the economy if you take the greater income of the people who have the talking therapy service and then divide it by the cost of that service. That gives you a benefit to cost ratio for the economy as a whole. And the answer in Norway was 4, which is pretty good. A 4-to-1 ratio. But in fact, if people recover from their depression or anxiety, it's even better, it's 10. So the key thing is really to make sure that we get people to recover. This is not just true in Norway, it's also true in Spain. This slide shows essentially exactly the same study done in Spain. The orange line is people who were treated in an IAPT-like system, and the blue line is people who got standard Spanish treatment in primary care. And what we're plotting here is the proportion of patients who have an income above the Spanish national average. At the start of treatment, most people with depression and anxiety don't have an income that high. Only a quarter of them do. If they're treated in the standard care, that stays the same 1 year later. But if you're treated in the IAPT service, then you double the number of people who now have an income at the average level. It goes up to nearly 50%. So psychological treatments are not just good for those people who suffer from mental health problems and for all of their family. It is also very good for our economies. So it's pretty stupid not to do it. And just to show you the data that I've just shown you on the effects on growing the economy was very persuasive to our government recently. This is the head of our finance ministry, our chancellor, Jeremy Hunt, and back last November he gave us an extra £580 million to further expand the IAP program, just based on hard economic data that shows that we're one of the most powerful things for growing the economy. So that's really covered all I'd like to say. We've learned a lot from the program, and if you'd like to know more about what we've learned about how to optimally organize services, you can download the NHS Talking Therapies manual, and you'll see the details there. The key things I've learnt, though, I think, is it's important to follow clinical guidelines, give people the best evidence-based treatments, train our therapists well to do those, and when you're talking to politicians, pay a lot of attention to economics, because that's what they're interested in. And you will only really be able to persuade your politicians if you're transparent. You collect outcome data on everyone and are able to show the benefits of what we do. And when you do that, it's important that the outcome monitoring is easy for patients. So we use mobile phones. People get a little text reminder before their appointment, and they can just fill in the questionnaire on their phone. It doesn't waste any clinical time. And it's really important that the leaders of your services are innovators. People who are interested in looking at the data and learning more from it, are really interested in those patients who are not doing so well and thinking, what can we do to try and improve it further? And I should stop there, but thank you very much for listening.